we are going to talk about DMGs, or donor management goals. We're going to talk about what they are and why you should care about them. So we want to today identify what they are, recognize the impact of achieving DMGs and how it correlates to an increased number of organs recovered and transplanted, and then apply lessons learned to improve organs recovered for transplant through the implementation of DMG monitoring and analysis. So yesterday, Dominic briefly mentioned when he was closing out the day about critical care endpoints. So that's what donor management goals are. There's 9 physiological parameters or critical care endpoints that we look at that help us assess and reflect the hemodynamic, acid-base, cardiovascular, respiratory, endocrine, and renal status of our potential donor or donor. And just for some background of where these 9 parameters came from, there is Dr. Darren Malinowski, I probably am not saying his name correctly. He is the Chief Clinical Transformation Officer for the School of Medicine at OHSU in Portland, Oregon. He did a lot of research on donor management, including incorporating these DMGs throughout a patient's admission as an indicator of successful recovery and transplantation of organs. And out of his research, a DMG work group was created. It started with 8 OPOs, and today there are 11 OPOs who participate that are throughout the country. We routinely submit our DMG data and meet regularly to discuss how standardizing, meeting these critical care endpoints can positively affect organ recovery and transplant. So what are the ones that we look at? So you have that white card, has our DMG goals listed. What's not on there is we look at our CVP, but we also can have started to look at our stroke volume variation as a parameter. Again, like this is a continual process that we are evolving and developing. So as we're meeting as this group, we're looking at what are critical care endpoints that we can use to help us, gauge how successful we're going to be. So that's one that's not printed on the card because we've kind of added it lately. But we look at MAP, CVP or SVV, the EF, your pH from a blood gas, PF ratio, sodium, glucose, urine output, and use of low dose or high dose pressors, depending. So those are the 9 points that we are looking at throughout a case. So here is a timeline. This is not as cool as Alex's timeline that she shared yesterday, but pretty simple. We look at this DMG data, these endpoints at 4 different points in the care of a donor. So starting with a patient has an injury, they're admitted to the hospital, they meet triggers, which Brian talked about yesterday, and hopefully within 1 hour, the hospital has referred this patient to Donor Connect. And at this point, we look to see what DMGs are being met. And then we also look at the time of authorization, at the time of our initial allocation, and then just prior to going to the OR. So those are the different time points that we are looking at. So why should you care about this? Why does this matter? So critical care professionals do play a central role in the medical management of our potential organ donors. Continuing to care for a patient, even though a poor prognosis has been given, until Donor Connect can come in and evaluate and look at the organ potential, not only preserves the option of donation, but it also, as we talked about yesterday, is a CMS regulatory requirement that we participate in, or are held to, I guess. And we have our referral coordinators who are the ones that take that initial call. And they, along with organ donation coordinators and our administrators on call, immediately start this evaluation process. We look at the donor registry. We look in through the EMRs to see what are lab values, what imaging is available, and we start gathering all of that data to help us assess and determine, does this patient have any potential to be an organ donor? Also, in addition to that, we are maximizing the available donor pool. That's a central role as a critical care clinician in an ICU. And we've talked about this. We have 2.1 million registered donors in Utah, and less than 2% of inpatient deaths qualify to be an organ donor. So we have a huge pool of people that would like to be a donor. It's a very small percentage that actually will be able to or qualify for that. So we really have to maximize our evaluation and our assessment of these individuals so that we can help close that gap between people waiting for a transplant and those who would like to be donors. And then also through a thorough understanding of the donation process, we can ensure that the opportunities for donation are not lost. So looking at this timeline again, where does the impact of the hospital come into play? Well, it's that first section, that pre-authorization or that hospital management phase. That is where you guys have one of the biggest impacts in the opportunity for someone to be able to be an organ donor. And we rely on the hospital to care for that patient from the time they're admitted until the time that we can evaluate and potentially authorize for them to be a donor. And then from that point on, we collaborate, the OPO, Donor Connect, collaborates with hospitals to continue to care for that patient. So we see those phases again. And then our goal during all of this is to, what we say, meet the bundle. And again, this comes from work from the DMG work group, who have found through research that if we can meet any 7 of the 9 DMGs, we have a greater chance of having better outcomes with organ donation and more organs donated. In addition, standardizing those critical care endpoints at the bedside of the potential donor will help improve the consistency of donor management and increase the number and the quality of the organs procured and transplanted. And this is like some information. I think Carrie is going to talk about this study a little bit more when she talks about utilization, but a study was done that found that when we meet the DMG bundle, so when we achieve at least 7 of those 9 DMG goals, our odds ratio doubles for having 4+ organs transplanted per donor. So what does that mean? Because I had to ask people about this because I'm not a stats person. So basically, if we can meet 7 or more of our DMGs, we are twice as likely to have 4+ organs per donor. Obviously, that's not every single time, but that odds ratio is in our favor for that. But I wanted to just pull a few cases from our OPO, from our DSA, to kind of illustrate this point. For me, this makes more sense than just looking at numbers. No offense to Brian, who had really beautiful tables and spreadsheets and whatnot. But so first, I wanted to pull one scenario. So this was a 38-year-old female who was declared brain dead after sustaining having a CVA and a subarachnoid hemorrhage. At referral, her DMGs met were 4, at authorization 5, initial allocation 4, and just prior to the OR 5. The expected yield for her was 3.14 organs, and that number comes from the SRTR that was mentioned yesterday. They're contracted, HHS contracted to track outcomes of donation, and they have algorithms. You plug in information, it pulls all this data, and it says, based on all of this, we expect you to have 3.14 organs for this donor. Our actual yield for this patient was 2. So I bring this up because we can see that we didn't meet the DMG bundle at any point in this case, and we not only had less than 4, but we didn't even meet our expected yield based on that information. I also recognize we could get into the weeds of why these DMGs weren't met. There probably are some that, based on this person's injury, we maybe never were going to meet. So we recognize that there are situations like that. However, striving to meet the bundle is what helps us see organs transplanted. And it's cases like this that we review in our DMG meeting. So with the organ donation coordinators, who are the ones that come on site, who collaborate with your hospital staff in treating these patients, we sit down every other week and we look at cases and we say, okay, you know, what could we have done differently? Where could we have improved? Or are there things that were out of our control? What's your experience? Have we had cases like this before? And we talk through these cases. The ones that maybe didn't meet DMGs, we also look at the ones where we did meet our DMGs and we say, what did we do differently in this case that made it successful? And I have seen a significant improvement in our donor management and us being able to meet our DMG bundle from having these discussions and talking through these cases. In fact, as I was going through looking for these case scenarios, I had to go back to last year, like a ways into last year, to find ones where we weren't meeting the bundles or we weren't having our expected yields met. And so that was really exciting for me to have to really like dig through to find some of these. So the next one is a good example. So here we had a 32-year-old female who suffered head trauma in an MVA. Now at the referral, she had 6 of her DMGs met, so not quite meeting the bundle, but we're getting closer. At authorization 8, at initial allocation 9, which means we met all of them, and then just prior to the OR 8. I think maybe her sodium had gone up a little bit. Our expected yield for her was 2.87. Our actual yield was 5. So we definitely surpassed that expected yield, and we had 4+ organs because we were meeting those DMGs, meeting that bundle. Okay, and then the next one I want to share is a 17-year-old male who was declared brain dead after an MVA that led to, like, immediately they knew it was a non-survivable head trauma. So when he came into the ED, they basically didn't treat. They knew family was, the only option really was going to be to withdraw. There wasn't going to be any treatment that could resuscitate him. It was non-survivable. So when he was referred, he only met 2 of the DMGs because they hadn't done any sort of resuscitation or interventions to treat. At authorization, we were up to a 3 because in that time period from referral to authorization, we realized this kid had potential for organ donation. And so we tried to collaborate with the hospital staff. Hey, can you treat this patient to preserve the option of donation? So we made a little bit of improvement. At authorization, we were at a 3. At initial allocation, 6. And then just prior to the OR, 8. So only at one point in those 4 timeframes where we look at the bundle, we met it at 8, and we had our expected yield 4 and our actual yield 4. Yeah, Woody?
Can I ask, just to kind of piggyback on that, how much extra time then did it take to get this donor to the point where we went to the OR? How much extra time in the ICU, how much more extra time did we buy at the bed?
Yes. And that's exactly why I included this case. So we see that, like, it took significant resources and time. I think this case lasted 4 or 5 days. With a otherwise healthy 17-year-old, it should not have taken that long for us to tune his organs up to the point where they were transplantable. So yes, it took time for this family. We had to ask them for time, and it, you know, we kept having to say, okay, well, we think we can place the heart, give us more time to see if it can turn around. It took a bed in the ICU. It took nursing staff and hospital staff. You know, it was a 1-to-1 nurse, so that's probably another nurse that they had to call in because of this. Supplies that we had to use, right? So significant resources. And granted, I realize we're talking somewhat in what ifs. Like, what if we had met the DMG bundle or had been close to it? Had they treated when he first came in? Would that have shortened the time? Would that have been less resources we had to use? We may never know. However, we can look through research and data and see that when we meet the DMG bundle, we have more success. And this was successful, but it took a lot to get to that point for us to turn things around. So yeah, thank you for bringing that up. So, you know, what does that mean for your hospital staff as we're talking about this? One thing that we've passed out is this CBIGS card. For those catastrophic brain injuries, we have, there are CBIGs, or catastrophic brain injury guidelines, which you may or may not be familiar with. And on the left-hand side, it talks about what are the goals, or what are the things that we're trying to accomplish, and what are the parameters that go along with that. So maintaining your adequate perfusion and fluid resuscitation, supporting a patient if they are going to herniate through brainstem herniation, so with pressors and fluids, watching for diabetes insipidus, preventing further ischemic injury to the organs, so making sure they're adequately ventilated, reducing their vascular collapse, and keeping them normothermic. So these things, if your clinicians are following CBIGs, these guidelines, you see that you probably are going to meet several of the DMGs just by following this guideline. So the reason I wanted you all to have these cards is between our DMG goals and CBIGs, we hope that that's something you can share with your hospital staff, that as we strive, like Brian said, as we're striving towards meeting these goals, we are going to see greater and better outcomes with organ donation. Yesterday, Jill talked about her call to action for us to support organ donation, and I just want to tack on to her. My ask is that we strive to meet DMG bundles in patients who are candidates for organ donation. So not de-escalating care once a poor prognosis has been given until we can determine whether or not that patient has potential to be an organ donor. And Carrie is going to talk about utilization, but we are constantly seeing advancements in how organs are utilized. We have aggressive transplant centers that call us and say, hey, if you ever have a liver that, Colorado calls us and say, if you have a liver that gets declined in the OR, like, we're interested. Florida has said, let us know about any kidneys that you have going on, because we'll probably take them. So there are centers out there that are super aggressive, and we're able to increase that potential through, taking care of these donors, knowing that we have aggressive centers. Patients who may come in and you think there's no way that this person has any potential to be an organ donor, you would be surprised. There are so many centers out there that really are pushing the boundaries and the limits of transplantation. And then by doing that, hopefully we help close the gap between organs available and organs needed for transplantation by supporting our potential organ donors. So that requires us to collaborate with each other as we are doing our evaluation and management of donors. I was actually just thinking yesterday about when I was on orientation, I went to Bingham Memorial, which is in your hospital system, and this was a patient who'd had a CVA. She was very unstable. The nurse felt really out of her depth. And for whatever reason, there wasn't a plane available, so we had to drive up. And I just remember we were road tripping up to Blackfoot on the phone with the nurse, talking through different things that she could do to manage this patient. Like, from the time that a patient is referred, if there is potential, we want to collaborate with you. We hope that you're utilizing these DMGs as a guideline, but we are available. We're resources to help take care of patients so that we can maximize their gift to others.